time it is. Marvin Devine, Hoover, Axel, and you know how we do. Yeah, I got the juice. Big game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, Axel, and Hoover, way too fireable. When this joint drop, better call the truth. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we link up. Let's go.
Good afternoon, good evening, good morning, wherever you're watching, welcome. And I mean welcome to another episode of Kidney Hub East Africa. I am half your host, Steve the Kidney Nurse. Good day. My hostess or my co-host, Brother Moses, will be joining us shortly. They recently had a blackout in Kenya. And so now he's charging his phone so he have power to be on. So please come on in. Today's topic or education session is going to be medications, flu and C-19, and the ESRD Network. Now, unfortunately, there's no ESRD Network in Kenya. There's not. So, we know that people on dialysis, regardless of where you're at, whether you're in Kenya, Zambia, Saudi, Asia, Puerto Rico, wherever, United States, wherever you're at, patients receive a number of medicines during and around dialysis sessions. You may be just started dialysis and you see the nurse coming to your chair and you're sitting there watching TV and they put something in your machine. You may or may not ask, what are you giving me, or what is that? Some people don't ask. Some people do. Or they may come around and give you a cup with some pills in it, but not tell you what is it for. And then you just drink it, or come with a cup of protein, that thick drink. Some places mix it with water and some don't. And when they don't do it, it's real thick. And the consistency is thick and it's sweet. That's called liquid-seal. And it has 16 grams of protein in it. And that's for patients who albumin level may be running low, below 4.0. But during dialysis, patients receive a number of medicines, like I said, during and around dialysis sessions, for safety, for anemia, infection prevention, and emergencies. And so today, we're going to talk about the common ones, why they're given, and what patients should watch for. And then we're going to move on and cover practical flu and C19 prevention steps for dialysis patients in the clinic. Just because we passed 2020 and you may not see a lot of people around you dealing with C19, it's still out there. And especially in nursing homes, rehab centers. So you still got to protect yourself, your family, especially if you just got a transplant. You should be wearing that mask. You should be wearing that mask. Don't take nothing for granted. But let's talk about common medications that are given during dialysis, right? Now, in the first one, you all know, well, at least I hope you know, the first one falls under anticoagulants, meaning blood thinners. Now, we have the one medicine that we give patients called heparin, okay? And, let me say hello to, before I really get into it, Michelle D. Thank you for coming, if you're still watching. Peace and blessings. And then Yvonne Gilmore. Peace and blessings, Miss Gilmore. Thank you for coming by. I hope you're still here. And then Miss Gilmore says, I have taken all my vaccinations, every last one of them. Okay, so Miss Gilmore is vaccinated. And especially if Miss Gilmore has kidney disease, she knows her immune system is low. Now that puts her at risk. Pneumonia, the flu. I don't know if she got a hepatitis B shot, but it's coming the fall season. So I now have my co-host who just joined in, okay, all the way from Kissimmee, Kenya. I want to give him the co-host welcome. So let me introduce no other than Brother Moses, the kidney ambassador. Brother Moses, welcome.
Thank you so much. Thank you so much, Brother Steve. I'm glad we have.
Hey man, I was getting worried. I didn't hear from you this morning. I was like,
Oh
oh man,
yeah,
I hope
yeah,
Brother Moses is okay. I'm sorry that you had
yeah,
blackout, but I'm glad you're not in a hospital or anything like that.
yeah.
So how's
So
it going?
it's great. It's great.
Mm-hmm.
And as always, warriors, it is a struggle as well. So I'm really glad and privileged to be here
Great,
today.
great. So,
Yeah,
Brother
yeah,
Moses, today, our topic is medications, flu, and C19 and ESRD Network. Now, I know over in Kenya, they may or may not have what they call networks. Here in the United States, they have ESRD, end-stage renal disease networks, that I think is maybe like 17 or 18 networks. Don't quote me, but they cover different regions of the United States. And we're going to go over that. I'm not sure if the same applies in Kenya, where they may have different networks that's throughout the country that um, give guidelines to kidney care, and if patients have complaints, they can reach out to them and they come and they don't come, but they give you guidelines on how to proceed with certain issues. So now we're talking about medications that are common, that are given during hemodialysis. And the first one that I was talking about were anticoagulants or heparin. Um, do patients in Kenya, I know you had to pay out of pocket for some medicines in Kenya, but is heparin a medicine that they use in Kenya to help the system from clotting? Is that a common medicine added into the
yes,
bundle?
yes. We also use heparin, which is in the package of national insurance, not for the hospital government hospital insurance. We have it, and we don't buy it. It is in the package. At least those are the one of the uh, minimum reducible package. Yes, so we have it.
Mm-hmm. So do you know how much
Yeah.
heparin you receive?
Uh, I think 2 meals.
Okay, 2 cc's, 2 milliliters, and that
Yes,
helps
and
your
they
filter.
dilute it.
And that helps your filter from clotting, the lines from clogging up. Correct?
Okay.
No, I'm asking you, or you don't know.
It's 2 meal.
No, but what I asked you was, and the purpose for giving that to you is to prevent your filter and your lines from clotting. Correct?
Yes, yes, true.
Okay, and that's the
Yeah.
purpose for heparin is to prevent clotting in the dialysis circuit, which are the lines. The circuit are the lines, the arterial line, the filter, the venous line right here. This is the circuit right here. And what happens if one's blood is thick and it goes through there and they on treatment for 4 hours, that blood can possibly clot the line. So the heparin, the purpose is prevent clotting in the dialysis circuit so treatment can be completed. What patients should know about heparin, you may feel a small, I'm sorry, what you should know is to report any unusual bruising or bleeding because normally the heparin is given when they put the needles in. It should be given in the venous line, and technically you're supposed to wait 5 minutes to let it recirculate in your system. But a lot of times now I see techs put patients on and give the heparin in the line. But technically you're supposed to give it through the needle, the venous, or if you got a catheter, give it in the venous side. And person's supposed to wait 5 minutes before they start treatment to let the heparin recirculate. So report any unusual bleeding. If you get heparin and you never had a bleed, if you got bleeding from, say, in your stool, nosebleed, heavy bruising, or with women, if you're still on your menstrual cycle, if you're having a heavy menstrual cycle, heavy bleeding, this is the time to tell the nurse so they can either hold your heparin or cut it in half or give you what we call tight heparin, like half a cc or 1 cc. Brother Moses, anything you want to say about heparin before we move on to the next medicine?
Oh yes. I understand there is heparin for loading, and then the one that I purposely, I don't know the other one, but there are two segments of heparin. One is for loading, that is placed on the syringe, and then there is one that they normally also put it.
It's maintenance. It's called the maintenance dose.
Okay.
Hello, Nikki, 4010. It's the maintenance dose. So,
Okay.
like you said, you're right. The one is the bolus, the
Yes.
initial heparin, and then you have one that's on the machine that it gives you a certain amount throughout your treatment. We call that maintenance dose or infusion. So, for instance, say your bolus is, like you said, you get 2,000 cc, 2 cc's or 2 milliliters bolus. Then you got a catheter, right? You still got your catheter?
Yes, I still got the catheter.
Yeah, so people may use a catheter. They may give you 1 cc an hour infusion. The machine is infusing that 1 cc per hour into the lines. In fact, I show this when I show these lines. This is the heparin line right here, and it's on the arterial line. This is the heparin where you hook the syringe up right here, and you put it in the heparin mechanism on the machine. You program how much heparin you want to give. If you want to give half a cc, 1 cc, 1.5, that's how much it's going to push in each hour, and you can set it when you want to turn off. So if you have a catheter, we set the heparin pump to go all the way, the whole treatment, so you don't clot if you got a catheter. Now, if you have access in your arm, like a fistula or a graft, we're going to set the pump to turn off 1 hour before you get off. So if you 4-hour treatment, we're going to set the pump to turn off at 3 hours. Because, we don't want the patient who got the access in the arm to bleed post-treatment. So that's why we turn off the heparin 1 hour before the person comes off. if you have a fistula or a graft. Okay, if you got a catheter, we set the heparin pump to stay on throughout the treatment. So the next common medicine that we give is for anemia. And that medicine is called erythropoietin, or EPO for short. Now, epogen or erythropoietin is a natural hormone that is produced by healthy kidneys. Okay. Erythropoietin is a natural hormone that is produced by healthy kidneys. A similar form of this hormone is given to the person on dialysis to help the body produce more red blood cells. Now, this type of medicine will increase your hemoglobin levels and help prevent anemia. Now, Brother Moses, this is the medicine where you may have to come out of your pocket and pay for. Is that correct? Brother Moses, can you hear me?
No, I didn't hear you. It hanged. No, I didn't hear you.
Yeah, I'm waiting for you to respond. Is this the medicine? Is this the medicine that people in Kenya have to pay out of their pocket for, the epogen?
Yes, initially, there are still hospitals that are demanding, but luckily where I am, we don't buy it. We no longer buy it. They have upgraded and we no longer buy it. But elsewhere, people buy it out of their pockets.
Okay,
Yeah.
so now, because there was a time you told me that you had to pay out of your pocket for this medicine. So now you're saying that it's included in the bundle.
Even before it was included, but most facilities deliberately never gave it, citing other reasons. And remember, I'm in a different facility that they have opted to take in that. The package, how the package works is that they can alter. They can say doctor consultation once a month. They cancel that and they give EPO. They keep on playing with it like that. So there are such facilities. So, for example, if the package says once a doctor consultation a month, which is in the package, then they can decide to cancel that and then to instead give EPO for free. But you realized that is a practice so that they maximize profit on that. They either do away with one and the other one you pay. You see? That is how they keep on playing with it.
So it's almost
Yeah.
like
But
taking from
most,
Paul to pay Peter.
yes, but before last year, people used to pay it. Most of the facilities, yeah, most of the facilities used to pay it.
Mm-hmm. Hey, Brother Moses, any way you can decrease the background noise?
Okay, let me just reduce the background noise.
Okay.
Yeah, just
Wait a
proceed as I
Yeah.
make it. Yeah.
So let's talk about, until Brother Moses come back, let's talk about erythropoietin for a minute. When you see the nurse come and they say, I'm giving you your EPO, find out how much you get. your dosage. Because see, this is like what Brother Moses said, how they play with the package over there as far as the bundle. It almost can happen here. And what do I mean by that? It's not a bundle, but it's called anemia management. Anemia management. And so let's take, for instance, you have a DaVita, right? Because most DaVitas use administrators. And what I mean by administrators, meaning people with no nursing or clinical background. We're talking about business degrees, okay, that are administrators. Now, when that happens, right? Okay, now when that happens, you got to have a clinical manager to do the anemia management. Now, say if that unit doesn't have a clinical manager, or they have somebody working on it and they overwhelmed. With the anemia management, what that nurse is doing is adjusting epogen dosage based on the hemoglobin. When we draw those tubes, the purple tops, and they do it every week, bi-weekly hemoglobins, and they adjust your epogen. So if there used to be a time, if your hemoglobin, they waited till you got to 12 before they start the epogen. They hold it when they got to 12. Now it's down in some places 11.5. Once your hemoglobin reach 11.5, they stop giving you the epogen, or they put it on hold, and then they wait for the number to trend back down. Once it trends back down, they restart the dosage at 25% less than what you received prior. This is how they keep making the adjustments. And for some people, may fall through the cracks. That's why you may say, oh, my hemoglobin was 11. And then two months later, it's down to 9, 8. And you start having symptoms. Symptoms like feeling tired, shortness of breath when you walk. It's because your blood count is low and the oxygen. So that's why we give epogen, and that's why you should know your dosage, know your hemoglobin numbers, what it is, and keep up on that. Seriously. Brother Moses, anything you want to say about epogen and your hemoglobin and what you
Yes,
experience?
possibly in terms of a question, because I'm also learning as well. What is the best ranges for to stop EPO or erythropoietin? Is it at 12 point something? And what it may be ranges that is minimum and maximum? What are the ranges?
Well, again, here in the United States, and it depends on the company. The company I work for, I'm not going to say, but they cut their epogen off at, if your hemoglobin gets to 11.5. Some places, or a while back, it used to be they wanted to keep your hemoglobin between 11 and 12. But see, it depends, because it's all about saving money. Because the epogen is expensive. See here, let me tell you, here in the United States, Brother Moses, they have different erythropoietin. I mean, they all do the same thing, but they got something called Mircera, Epogen, Adherence, and they give in different times. Like the Mircera, which Fresenius owns. That's why if you go to Fresenius unit, you may get Mircera. They give that every 14 days. Right? The Adherence is weekly, every Monday. And then the Epogen, they give it to you 3 times a week. So each time you come to treatment, you get your Epogen. But the other ones, like the one is every 2 weeks, and then the other one is every week. Now, different companies tried all of them to see which one's going to save money and which ones are more effective. And a lot of these companies came back to Epogen because it's pretty much, I don't want to say cheaper, but when you got a vial and you got 20,000 units in a 2 milliliter vial, and it's 10,000 units per ml, or the strength may be 20,000 units. I'm sorry, 20,000 units per 1 milliliter. That means the dosage, like if person gets 2,000 units and you got a 20,000 milliliter vial, you're not going to draw out very much in the syringe because of the strength of the medicine and the dosage. But the other ones, the Mircera comes in a syringe that's injectable. So if you get 30 micrograms, there's a box with a syringe already pre-filled with 30 micrograms of Mircera, and you inject it in, throw it away. That's expensive. When I say expensive, meaning it already comes in an injectable, a large syringe. I'm talking about the medicine and inside that syringe to make the syringe, opposed to drawing medicine out of a vial. And so, again, I don't expect people to go in here and be experts on this, but what one should know is when it comes to your anemia and hemoglobin levels, you should know that medicine dosage that you get, because you got shortage of personnel here, and you got somebody to come from another unit and they don't know you. Not saying they're going to mess up to give you the medicine, but if you've never seen that person before and they give you medicine, I would want to know, are you giving me my right dosage? And in order to know they give you the right dosage, you got to know how much you receive. Now, Brother Moses, do you receive Epogen?
Yes, I receive it.
You know your dosage?
4,000 units.
Okay.
Yeah.
4,000
Yeah.
units. Okay,
4,000
each treatment,
units.
right?
Each treatment. But sometimes, I guess at one particular time, I was told that I'm at 12, so I can skip. Maybe I skip 1 week, and the other week I'm given at 12.
No, right. Michelle D. No, you said so the EPO should be continued unless hemoglobin. No, that's not what I'm saying, because I said there was a period of time where they would cut the EPO off once your hemoglobin reached 12. But now there's studies that say now they want it 11. It could be a money thing, but there's and I may talk about that tonight if I could find my information sheet on erythropoiesis, ESA, erythropoiesis stimulating agents, because there's risk to these, far as raising your, because if you got a high blood pressure, say 190 or 200, they should hold that dose until your pressure comes down, because it can increase your blood pressure. And when you start getting above 12, you could maybe run into some problems. But now, again, some places, if it goes over 11, they say hold it until that number drops. And when that number drops and goes below 11, then they'll restart Epogen, but 25% less than what you received prior. So Brother Moses is getting 4,000, and he goes to a unit where they cut the EPO at 11, and he's 11.4. They did a hemoglobin test, and it comes back where his results 11.4. Hold his EPO. They're going to hold it. 2 weeks later, they do another blood draw. They do it, and his hemoglobin dropped from 11.4, say, down to 10.5. Now they're going to restart the Epogen, 25% less of that 4,000. So what we do is, I believe they multiply it. So the person's getting 4,000 times 0.25, I believe. So that comes to 1,000. So we'll subtract that 1,000. Don't quote me on this, from the 4,000. So instead of him getting 4,000 starting back, we're going to start him back at 3,000. And this is how they do it. They play almost like a seesaw. Some patients' hemoglobin go up and down, and they make the adjustments. So that's why you can see some people like, my hemoglobin dropped. You got to make sure that they're doing the anemia management. Or if your hemoglobin drop, it could be a sign that you could be losing blood too. Most patients, on the average, have issues with their GI, where they're losing blood coming through their stools. That's why they ask if your hemoglobin drops and it's not coming up, even when they're giving you Epogen, somewhere you're losing blood. That's why they say they give you this test called the GUAC test, where it's a stick and this pad and this it's not a kit, but it's a cardboard type test that you get a sample of your stool, you smear it on it, right? And then you close it, bring it back, and they put a reagent on there to see if it reacts. And if it turns certain color, that means that it's positive for blood in the stools. So Nikki said I did it one time a week. And that must have been, I wonder if that, was it the one in the yellow? The injectable, the Airnest? Because that's normally what they would send home to some people is the injectable. It's already in the syringe. All you got to do is put it under the skin. The needle is real small. And you inject it and you pull the piece up and it closes up. So, all right, let's talk about the next medicine, which follows behind epogen, and it's iron. Oh, okay. It's iron. Now, you need iron to help with the hemoglobin. Iron helps your body make hemoglobin. It is used to increase iron levels in the body and work with erythropoietin to prevent anemia. You need that iron. Like, so if your iron stores are low or your iron saturation, again, that's why one should know their labs. And your iron sat, if it's below 20, you may have some issues. Now, let's get back to one thing about epogen. What patients should know: it helps reduce fatigue and the need for blood transfusions. Requires, which I already said, monitoring of hemoglobin. You gotta monitor the hemoglobins. And again, if you go to a facility where the administrator is not a nurse and they don't have a nurse to do the anemia management, or they fall behind, that could be bad for people who are not getting their levels monitored. And it may fall down to a level that may impact the patient. Okay. And it helps prevent getting blood transfusions. But if your hemoglobin, if your hemoglobin gets down too low and it affects you or impacts you, they may request for one to get a blood transfusion. Brother Moses, do they get blood transfusions in the unit in Kenya?
Yes, they do. The patient who, because of lack of knowledge elsewhere, they have been doing dialysis. We have even poorly managed dialysis because it is now a business. So you realize that the actual thing is never done in certain dialysis units. Then one goes on getting weak to the extent that they refer him or her to a better unit. Now, when that one happens, one comes with a hemoglobin of 6. So definitely, you will have to be transfused, and they normally request someone to donate, and they are transfused. They go to the blood centers, and then they donate over there, and then the nurse will go pick that which is ready and is to get transfusion. Yeah, while on dialysis, intradialysis.
Yeah, they used to give blood on dialysis here, but now they don't do it in the units. They require the person to go to the hospital, and they give it in the hospital because Medicare doesn't reimburse, and the company here will have to eat their cost of getting the transfusion from Red Cross. But I want to answer Michelle D's question, which is a very good question. She said, if the blood loss is not GI related, could it be due to low kidney function? And no. You got to look at what's causing that blood loss. If it's not GI related, does the person have sickle cell? Is there any other reason internally? It could be internal. But you definitely will have to get that investigated. Seriously. That possibly, if you're having problems with that, they may even send you to a hematologist to get an eval. And I'm sorry to hear that, Nikki. Nikki says she just had 2 transfusions. See, this ain't no joke. And that's why we tried to do this education, so people can learn, let me keep up with my hemoglobin. And some people go ask, you know what your hemoglobin is? No, what is it? Now, I'm not saying know everything, but when it comes to your health and dialysis treatment, we want you to just keep abreast, because it's going to get worse in the clinic. What I mean by that here in the United States, far as staffing, and when you start getting short of staff, especially nurses, a lot of things get missed. But if you're on, or if you're abreast of your medicines, what you get, write them down. Then you can be one step ahead of the game. Now, with the iron, you have different iron medicines. They all do the same thing, pretty much. You got Venifer. You got one called Felicit, ferrous sulfate, and ferrous gluconate. Then they had one called Enfed. A long time ago, where people used to have a reaction, they start itching. We had to give them Benadryl because they was having a small reaction. So they went to start coming out with like Venifer and Felicit. But how they normally do that iron, is, say the doctor may order 1,000 milligrams. Say he ordered 1,000 milligrams of Venifer, right? Now Venifer comes in 100 milligrams and 50 milligram bottles or dosage. So if you was getting 1,000 milligrams, we'll give you that over. We'll give you 100 milligrams times 10, meaning up to 10 treatments, you'll get 100 milligrams. Monday, say you go Monday, Wednesday, Friday. Monday 100, Wednesday 100, Friday 100. The following week, same thing until you reach 10 dosage. Once that happens, then they may start you on 50 milligrams every week as a maintenance dose. So they already loaded your iron stores up ferritin. Now we're going to give you 50 or 100 every week to maintain your levels. Comment by Michelle D. My mother-in-law, 85, has low kidney function. She denied dialysis and she gets blood like every 3 to 4 months. She currently gets Hinton infusion. I never heard of that, Hinton infusion. So I would definitely please elaborate on that. But if let's see, do all the iron medication make people sick on the stomach? Nah, it depends. Everyone's different, but are you talking about the pills, Miss Yvonne, or the IV medicine? Because with the IV, we're supposed to put in a little bit at a time. Now, I've heard some patients' stomach get act up if the nurse like slams it in, meaning just give it all, like right there, instead of giving a little bit, come back, giving a little bit more, come back. But no, I haven't heard about recommend for people to eat before we give the iron. But some, all medicine has side effects. It may, react. You may react different than someone else to the medicine. But if that's the case, they should be giving it to you real slow, a little at a time. Someone may just be standing there and push it all in. And then that could be the reason why you having upset stomach. But they come and just give a little squirt here, come back. But see what happens when they do that, they may forget because they may get busy. And then when they remember, they come back, the technician and already took you off the machine and the medicine is still hanging on the side of the lines. A lot of times we give the iron medicine in the venous line in this side port right here. The pill form. Okay, now, Miss Yvonne, yes, that can upset your stomach, the pill form. And in fact, the pill form can cause constipation. That's why when someone gets on dialysis and they still taking the ferrous sulfate tablets, the nephrologist says, stop taking the tablets because we give it to you IV. And if you're having issues with the tablets with constipation, you may want to try Miralax to help, with the constipation. But so you said, that's interesting that Michelle, your mother-in-law, denied treatment. Because let me tell you, a lot of people don't know about that's a treatment option. Anybody watching that didn't know, you have hemodialysis, outpatient. You have home dialysis, home hemo, peritoneal, transplant, and something called conservative therapy. And conservative therapy is the same as no dialysis at all. That's a treatment option, no dialysis. Now, some people ride it till the wheels fall off. And what they would do, if you opt to do no therapy, no dialysis therapy, they're going to do all they can, give you medicine like Bumex or Lasix that try to get you to keep urinating. They're going to tell you to your diet, reduce your potassium intake, your phosphorus, your sodium. They're going to try to keep you manageable as long as they can. Now, everybody's different when it comes to this. I seen a lady on TikTok. Her name was Jeannie Button. Rest in paradise, Jeannie. She was on dialysis maybe 16, 17 years. And she decided to stop treatment. Go on TikTok and look up Jeannie Button, GENIE BUTTON, and look at her journey. She documented when she stopped dialysis. Been on dialysis 17 years, stopped treatment. Guess how long, Brother Moses, she hung in there? Guess. Just give me a number. How many months you think?
Not much sure.
Just a rough guess. How many months you think?
Maybe 6.
24 months. 2 years. She was on hospice. 2 years.
She managed it, and she managed it without dialysis.
Yes. 2 years. You can go look it up. And she lost the battle this year.
But I guess every patient has different needs.
Exactly.
Okay.
All right. Let's move on because we've been on here for a minute, like 58 minutes. But yeah, Brother Moses, 24 months. So everyone is different.
Yeah.
Let's talk about the next medicines. Oh, with the iron. Where is it at? Again, the purpose of iron, what we just talked about, is to replenish iron stores to support red blood cell production, often given during dialysis for convenience. So you come in, they tell you, like if Miss Gilmore was to come into dialysis and she's taking the pills, the doctor says, stop taking the pills. We're going to give it to you IV. It's more convenient. What patients should know, it could cause a reaction. It may cause a temporary reaction in a few people. Itching, hives, and then we administer IV Benadryl or diphenhydramine. That's the generic name for Benadryl, diphenhydramine. What else about iron? What patient? Okay, we talked about that. Again, if you start getting iron for the first time, you watching this, and you start itching or got hives, you're more than likely having a reaction. Now, Brother Moses, iron, is that one of the medicines that fellow Kenyans have to pay out of their pocket?
Yes. So many medication. The only medication which is given on dialysis package is iron sucrose, ions, then EPO. Only that. That's the only medicine that is given. Everything other than that, as we speak currently, because most hospitals now have adhered to the package and they no longer exploit. But then currently, the only medication that is in the package is that EPO and iron. If you get infection, you still buy.
Right.
Yeah,
Right.
it becomes your own business. If you get infection, you buy. You have something you need, like to buy, say, binders, you will have to buy. And they're very expensive here. Very expensive. I mean, just name it, you will have to buy. Other than the two are provided in the package. The rest you buy.
And see, here in the United States,
Yes.
people are definitely fortunate that Medicare pays for those binders for some people. Or it comes with, again, the packet. We get binders out during treatment. And speaking of binders, let's talk about that. Chronic kidney disease, mineral, and bone disorder. Because that's what the binders are for chronic kidney disease, mineral, and bone disorder.
Yeah, that is normally what I'm currently suffering from. I've been suffering very critically on bone and mineral disorder. Yeah.
And this is why right before this show, I was talking about herbal tea supplements, where you had a gentleman reaching out to one of these supplements on the feed on TikTok asking, he's been on dialysis 20 years. 20 years he's been on dialysis and want to know will this tea help him get off. Now, the thing is, when you got people who don't know and that are ignorant to the fact that these teas don't work and they're not regulated by the FDA, Federal Drug Administration. Why spend your money on something that you don't even know where it was packaged, if it actually works? Because if that was the case, again, we would be getting people off transplant lists, off dialysis, fast, quick, in a hurry. The budget or people in Kenya and the insurance that handles that, they wouldn't need to do it no more because we can get the people off dialysis. If these supplements really worked. And now when you come, somebody been on dialysis, Brother Moses, he's been on dialysis. How many years, brother? 9 years? 10?
Yes, now 9 years now.
And of course, if these teas work, I'm sure Brother Moses would have been tried it. And then if you had to think about this before we move on to these medicines that deal with the bone disorders. If you've been on dialysis for 20 years and you had other issues evolve out of that kidney disease, like bone issues or nerve, how is a T going to restart the kidneys and then correct the damage or the other issues that it's caused? Another medicine that we give that's common during dialysis is for vitamin D, which chronic kidney disease, mineral and bone disorder, is a medicine called calcimimetics. Calcimimetics that enhances the action of calcium on specific body tissues to cut the amount of parathyroid hormone or PTH in your blood when kidney failure has caused PTH to increase to an unhealthy level. Now, I talked about PTH production many times and the medicine they give for that. And some people may have to get what they call a parathyroidectomy, where they remove the parathyroid glands. Now, examples of these calcimimetics are cinacalcet, those orange pills. I'm sorry, cinacalcet, the green pills, the Sensipar, the 30 milligrams, and something else called Parsabiv. And then you got activated vitamin D, a prescription form of vitamin D that may be used alone or with a calcimimetic to treat high levels of parathyroid hormone. Another example of that is calcitriol, those orange pills, or something called paracalcital, which is Zemplar, an IV medicine. Brother Moses, anything you want to share about these calcium medicines for chronic kidney disease, mineral and bone disorder?
Yeah, I know of. There is another one that contains calcium and vitamin D. It is called here Gemcal. I don't know whether it is available in US. It is called Gemcal. We have another one called calcitrol, which
Yes.
also has, which also has vitamin D. Yeah. Uh-huh.
So, Brother Moses, Nikki want to know, do you have problems walking?
Absolutely. I don't walk. Currently, I don't walk completely. I depend on a motorbike taxi to move around.
What about
However,
in the house?
most of the time I'm in the house, but I can help myself using a walking stick just for short distances.
Right.
To go maybe pick something next shop, then come back.
Right.
Yeah,
And
yeah.
then Nikki said, will a transplant help them? If so, the damage is already done. A transplant will help, but the damage already caused from the kidney disease, the bone disorder, that damage is done. But the transplant will work. And unfortunately, with some people that's dealing with this calcium phosphorus disorder, they may build up something called calcium deposits or calciphylaxis in certain arteries or veins that may prevent one from getting a transplant. Oh, Tabitha's on here. Brother Moses, friend from Kenya. She say, when they are on dialysis for long, the bones so easily break, the bones become weak. Yeah, and this is why taking the bone medicine, the vitamin D or the calcitriol or the Sensipar, these all work hand in hand. And unfortunately, some people, we give them the medicine to take it and say, I want to take it when I get home. And they never take it. They may forget. And a lot of people who in the past they refused these medicines after years, and then they may have a change of heart. Say, I want to get on a transplant list. And then when they go for the workup, that's when they notice that they may have some arteries that's calcified and didn't even know. Thus, for some or many, rendering them ineligible for a transplant. Now, let's talk about one more medicine that we give. It's a supplement, protein supplement called Liquicil. Now, this has a whopping 16 grams of protein. Now, listen to this. Protein is needed to strengthen and maintain muscles, to fight infections, heal wounds, and balance fluid. People with low protein levels are more likely to get sick, are hospitalized more frequently, and have a higher unalive rate or death rate. Protein supplements given during dialysis can help improve your blood protein level. And I wanted to answer this question for Mrs. Gilmore. She's like, what causes this? Those issues with the calcium and phosphorus, because when your kidneys don't work, it's not making that activated vitamin D. And I don't know if you're on TikTok, Ms. Gilmore, but I may talk about that tonight, PTH levels again. But yeah, when the kidneys are not working, it's not activating the vitamin D. So with some people, you may see a seesaw where you may have the phosphorus up and the calcium down. Your phosphorus may be high, your calcium may be low, or vice versa. Your calcium may be high and your phosphorus may be low. You're trying to balance this out. That's why the kidneys are so important, because they regulate and do so many things. Oh, okay. Brother Moses.
Yes.
We got a couple of questions for you. Miss Gilmore wants to know what caused your kidneys to go out.
There was an obstruction.
Okay.
Yeah. Remember?
Okay. Oh, what was told to you before? Remember, that was told to me before. Here I am with a new kidney. Oh, you talking about the calcium deposits, Miss Nikki? Are you asking Brother Moses his dry weight, or You asking me what is dry weight?
My dry weight is 49.
Kilograms, right?
Yes, kilograms.
So, but Miss Gilmore, dry weight is your weight without any excess fluid on. Your dry weight is your weight without excess fluid. And Nikki, wow, that's crazy. Did you go get a second opinion? Oh, I'm not on dialysis, Miss Gilmore. I'm a kidney nurse. But the dry weight is your weight without any excess fluid. So that's why one should know their body and know what they feel comfortable, their dry weight, looking to make sure if you got any fluid in your ankles called edema, or fluid under your eyes, facial edema, or what we call around your eyes, orbital edema, or if you can breathe. Like if you coughing a lot and it's a wet cough, then you more than likely may have fluid in your lungs. Oh, okay. Okay. Got you. Okay. So thank you for sharing that, Nikki. And Nikki went, is what I understand, she was told that she had maybe calcium deposits or or calcium that maybe rendered her ineligible for a transplant. And she said she went and got a second opinion. That's what I understand. And now she's sitting here today with a transplant. That's why it's important to always get a second opinion. Okay, she said they seen something completely different. All right. Now we gotta finish this show. We almost there, Brother Moses. Now let's talk about protecting oneself from influenza and C-19. Now I'm gonna tell you, a lot of people are on the fence or have different opinions when it comes to vaccination. I'm just giving the information. Now, they say influenza, the flu from the influenza virus, and C-19 from the SARS-CoV-2 virus can be very contagious and spread quickly. And we've seen that in 2020. Your kidney disease puts you at a higher risk of getting influenza and C-19. Now, they say the best way to protect yourself from influenza and C-19 is by getting vaccinated or boosted. Now, again, I'm not denying or promoting because everyone is different when it comes to vaccination. What I can say that I've vaccinated many people and they had no issue. In fact, they didn't, have the flu. So it depends on your beliefs. But they say, vaccines work. Oh no, let me see. Even found a ad spot if I need a sixth kidney. Wow. Wow. So let's look at other tips to beat flu and C19. Well, first of all, Brother Moses, how is the flu and C19 in Kenya right now? Is there
Yeah,
on
C19,
the rise?
we have rare cases, but then flu is quite common and frequent in dialysis. So most warriors are asked to have mask on. Yeah,
Do you still wear masks?
yes,
Okay.
while on dialysis.
Okay.
So
Okay.
flu is quite common. It's a frequent thing. Like in every session, you must get about 3 or 4 with some form of flu.
Hmm.
Yeah.
Do they recommend it or make it mandatory for patients in Kenya to get the flu shot?
Yeah, they just advise, but
Okay.
it depends on uh, the service provider at various facilities. There are those who do not uh, put on strict measures on such, but elsewhere there are other high-end facilities that people top up. So there is every service that you will need to be provided, including vaccinations.
Oh, okay. Tabitha said they recommend. Okay. Great. Thank you for mentioning that, Tabitha. Now, here go some other tips to help beat flu and C19. Practice regular hand washing with soap and water. Do they encourage that, Brother Moses, at your unit, hand washing?
Yes, that is the standard procedure provided. But now the problem is they don't do it the right way, the way it ought to be done. Yeah, you can notice that someone just very funny and interesting things happen. You realize that a caregiver, a health, a health provider, you know, goes just just put some water flowing on his hand, then assumes he's done it without soap, without anything, and he comes.
So they're
So
not using proper hand
they are not
hygiene.
using it proper. I think the usage that I see across dialysis I've gone to, units I've gone to, is just to keep the law alive. That, oh yes, I've I've done some hand hygiene, I've performed some kind of hand hygiene. But the question is, have you done it properly? The most critical question.
Mm,
Mm.
mm. Yeah, that's true. Why don't doctors wear masks yet tell us to wear them? That's a good question. Seriously, because you see doctors come in sometime that don't put on gloves in the hospital and they touching patients with their bare hands. So it boggles my mind as well, Nikki.
Very true, because Nikki, you will realize that I think it is a question of getting used to maybe the procedure. And but for nurses are very good at maintaining that hygiene. But doctors, I don't know what normally happens. They want to access you without gloves. You know,
Yeah.
yeah, it does happen. Very true.
All right. Another tip, if you are not feeling well or if you were exposed to someone who tested positive with influenza or C19, call the dialysis unit nurse first before going to or missing your dialysis treatment. So even in East Africa, if you find yourself not feeling well and you've been exposed or near someone with one of the two, you want to call the unit if you can to let them know what's going on. Now, Brother Moses, let me ask you, if someone has been identified to having C19 or the flu, do they still treat them at the unit? Or
No.
I just say with C19, do they
For
separate them from the other patients?
for C19, the practical thing I've seen is that if they suspect that, you are isolated and referred to a government hospital for C19.
Oh, so they recommend you going to the hospital and not coming to the unit.
Government facility.
That's understandable.
Because what happened, the picture is, let me just paint the picture how private facilities looks like and operate. You know, private facility, they maximize number one on space, and they also want to maximize on profit. So, for example, if you are a patient with the special need, say hepatitis, they don't have they don't spare one machine for special case like that. So instead, they will give you a referral to go to a government facility. And of course, earlier we have discussed how government facilities has so many challenges that comes over there. So definitely they don't allow some cases to be handled in the facility, private facility. Reason being, they have not planned for that because these are businesses. They have to maximize on profit. Yeah. Mm-hmm.
Okay. Also, another tip to beat flu and C19, regularly clean and disinfect surfaces and objects that may be easily contaminated, like your doorknobs and countertop. Now, I always say that to patients here in the United States, like when you go to dialysis treatment, like the door, if it got a handle going into the unit, think about how many people touch that same doorknob day in and day out, because the cleaning companies and we don't wipe the handle off with bleach rag. Same with the bathroom. If you go use the bathroom in the patient lobby, right, and someone say has a bowel movement and they wipe themselves and then touch the handles of the sink, or they don't wash their hands at all and touch the door to come out of the bathroom. Not everybody washes their hands. So I always suggest if you go to a clinic, if you can get your hands on some gloves, maybe wear a glove and use that glove to open the door handles and take that glove off. I know it may sound a little extreme, but just think about it. You got a 24 chair unit. outpatient unit, you got different patients, different staff, different people coming in and out, opening the door, touching the handles, and they possibly transmitting germs. That's why when you go to dialysis outpatient, right near the scale, they should have a sink with paper towels, soap, cold and hot water, so you can wash your access on your arm to prevent and reduce the spread of infection. So again, clean, it says regularly clean and disinfect surfaces and objects that may be easily contaminated, like doorknobs and countertops. Yeah, thank you. But yeah, seriously. Especially if you got a catheter and your immune system is low. It's coming the winter months, October. And we know that's a lot of time between September and what, February. People getting sick. And we may see a rise in flu cases this year. C19. And so here's what the CDC says. Did you know flu vaccines have been shown to reduce the risk of having to go to the doctor with the flu up to 60%? And then here's our challenge to you. If you feel any of these symptoms, call your dialysis nurse before coming to your next treatment. Fever at or greater than 100 degrees. New shortness of breath. New cough, sore throat, or runny nose. Chills. Fatigue or feeling more tired than usual. Headache or muscle aches. New loss of taste or smell. Nausea, vomiting, and diarrhea. If you experience any one of these symptoms and you go to outpatient dialysis, call and let them know, or call your kidney doctor. Now, last but not least, now, Brother Moses, do you have anything to say about that before we move on to the last topic about
Yes,
protecting yourself and the symptoms that I just mentioned?
yes. Because it is very important to actually seek any advice regarding all those symptoms, because what most of us do is to overlook the symptoms, not knowing that they are indicator of something serious that is coming. Yeah.
Okay. All right. Amen. And last but not least, end-stage renal disease networks. And we know that they don't have them over in East Africa, but here in the United States, they have what's called ESRD Network. And what they do, under the direction of the Centers for Medicare and Medicaid Service, CMS, the ESRD network supports the renal community in ensuring safe, effective, patient-centered care. The ESRD network responsibilities include the quality oversight of the care ESRD patients receive, the collection of data to administer the National Medicare ESRD program, and the provision of technical assistance to ESRD providers and patients in areas related to ESRD. And then they say, call your ESRD network for support in any of the following: online support groups, investigation of grievances, patient mentorship program, getting ready for emergencies. And you get that information from your support. Now, I think there's like 17 or 18 networks across the United States. And each of them cover a specific region. And so, with that being said, we come to the end of this. Brother Moses, anything you want to say about what we talked about today? Medications given during dialysis, bone disease disorder, protein supplement, or protecting yourself from influenza and COVID. Anything you want to mention before we
Yes,
close the
I
show?
just want to add on it in a way. Let me just cap it that it is very important to really work close to your nephrologist, kidney doctor, so that when there are medication that need to be adjusted, you can always be up to date. When there are other screening to be done, and so forth and so forth, then you are up to date, so that you don't come to a point where it is too late, or now it become critically an emergency issue, Brother Steve.
I agree with you 100%. I agree with you 100%. Well, this has really been a great show. A lot of good information. Thank you, Ms. Gilmore. Appreciate it. Nikki and everyone who tuned in. Michelle D, Nikki, 4010, Tabitha from Kenya. I mean, we know with a lot of this information may sound boring to people, or they may say, hey, I don't want to, not today, Steve. I deal with dialysis 3 times a week. And that's understandable. But there's a lot to learn about this disease, especially if you're on dialysis, so you don't fall victim to issues that may happen during dialysis. And if it does happen, then you know what's going on. Seriously. Because take a case, for example, if your filter, right, this right here, if this filter clogs up, or the lines, and they can't return your blood, and they throw everything in the trash, you may not think nothing of it. But you need to say, hey, we need to draw my hemoglobin to see if you lost any blood. Of course you lost blood, but did your levels drop? This is where you need to let your kidney doctor know that your lines clotted, or they threw it away and you didn't get your blood back. So you want to check to see what your hemoglobin is. A lot of people may not understand or realize that. And one thing before I leave, let me put in reaching your full potential with health equity. And this is for people in the States or who watching this. And even Kenya. But we know that Kenya and East Africa have issues when it comes to reliable transportation. Social determinants of health. Reliable transportation can be a major barrier to getting to your dialysis treatments and doctor's appointments. And then they go on to say, talk to your social worker about potential transportation benefits from your insurance company, because they ask what type of insurance you got: Medicaid, Medicare, or private insurance. Some of them, like the Medicaid or private insurance, may pay for transportation, but Medicare won't. But if you're having issues with getting the dialysis or your transportation, talk with your social worker. Brother Moses, before we close the show, anything you want to say outside of what we talked about?
Well, I just want to thank every viewers that we've had today for supporting this program, especially Tabitha. I also just called her yesterday to check on her, and indeed she promised that she will be here live. So thank you, Tabitha, wherever you are.
Oh, okay. Thanks, Tabitha.
Yeah. I just called her yesterday, and I informed her that we'll be going live. So try and attend, and indeed she had agreed.
Yeah.
So it means of all the people I called, she's the one who is standing out. So she's really a big encouragement to us.
Oh,
Yeah.
great. And Tabitha, let people know, I'm sure you do in Kenya, the patients that you maybe work with about this program. Hopefully it can give some hope. All right, Brother Moses. Hey, it's been a great show. I got to get myself ready for work tomorrow. But I see you next week. Again, I'm glad you was able to get on the show with no problems because of the blackout. And have a safe treatment this week. And we'll see you next week, along with everyone else. We see you next week. I'm Steve, the kidney nurse, along with Brother Moses Kennedy, also known as the Kidney Ambassador. And we'll see you next week. Take care, everyone, and have a great day. Peace and blessings. See you later, Brother Moses.
See you too, brother.
All right.